Hello, this is Dr. Joel Gorfinkel, and I want to thank you for joining me in my presentation of Advances in Heart Disease, a Chronology. This presentation was first given in 2002 and then presented through the years with constant tweaking. The materials contained in this presentation are from my own personal collection and from the internet. I apologize for not giving credit by name to all those whose material I have used. I wish to acknowledge all of them as a group. I have no disclaimers to make. In 1711, Stephen Hales conducted the first catheterization in a horse using brass pipes, a glass tube, and the trachea of a goose, and then measured the height of the spurt of the blood column. In 1844, Claude Bernard inserted a mercury manometer into a horse's carotid artery, advanced it across the aortic valve, and termed the technique cardiac catheterization. In 1870, Adolf Fick described a method for measuring blood flow as cardiac output equaling total oxygen consumption divided by the difference between the oxygen value in arterial blood and mixed venous blood. In 1929, Werner Forssmann in Germany first inserted a catheter into the vascular system of a human, his own. He placed a urinary catheter into the left antecubital vein and pushed it as far as it would go. He then walked to the radiology department to obtain a film that demonstrated the tip had reached the mid-right atrium. Here is the original X-ray film that he took of that catheter that he inserted through his left antecubital fossa into his right atrium. Andre Cournon, D.W. Richards, and Werner Forssmann shared the Nobel Prize in the 1950s for their discoveries concerning heart catheterization and pathological changes in the circulatory system. In 1953, Seldinger described the percutaneous approach to left and right heart catheterization. Dotter and Gensini developed specialized catheters, and these were used to do diagnostic procedures necessary to perform corrective valvular and congenital heart surgery. The first selective coronary angiogram was done by Mason Sones in October of 1958, quite by serendipity.
In Cleveland, Dr. Mason Sones and his colleague Earl Shirey were developing an imaging technique that would make it possible to selectively photograph the coronary arteries in action. Dr. Sones' initial discovery came about virtually by accident during an aortography procedure. He writes, "It was late in the day and we were tired. I hit the switch to rev up the X-ray generator so I could see. As the picture came on, I could see that the damned catheter was in the guy's right coronary artery, and there I was down in the hole. I yelled, 'Pull it out! Pull it out!' By that time, about 30 cc's of the dye had gone into the coronary artery. I climbed out of the hole and I grabbed a knife. I thought that his heart would fibrillate and I would have to open his chest and shock his heart. But he didn't fibrillate. His heart stopped. I demanded he cough, and he coughed 3 times, and his heart began to beat again. I knew at once that if the heart could tolerate 30 cc's of dye, we would be able to safely inject small amounts directly into the coronary artery. I knew that night that we finally had a tool that would define the anatomic nature of coronary artery disease." In Cleveland, Dr. Mason Sones and his colleague Earl Shirey were developing an imaging technique that would make it possible to selectively photograph the coronary arteries in action. Dr. Sones' initial discovery came about virtually by accident during an aortography procedure. He writes, "It was late in the day and we were tired. I hit the switch to rev up the X-ray generator so I could see. As the picture came on, I could see that the damned catheter was in the guy's right coronary artery, and there I was down in the hole. I yelled, 'Pull it out! Pull it out!' By that time, about 30 cc's of the dye had gone into the coronary artery. I climbed out of the hole and I grabbed a knife. I thought that his heart would fibrillate and I would have to open his chest and shock his heart. But he didn't fibrillate. His heart stopped. I demanded he cough, and he coughed 3 times, and his heart began to beat again. I knew at once that if the heart could tolerate 30 cc's of dye, we would be able to safely inject small amounts directly into the coronary artery. I knew that night that we finally had a tool that would define the anatomic nature of coronary artery disease."
The 1960s Sones, Judkins, and Omplots perfected the techniques of using various types of catheters, both from the arm and from the leg. This is the Judkins-shaped catheters. This is the Sones catheter, which took a little more technique than with the Judkins technique, and this is the Omplots catheter. These are the giants of those early days: Sones, Judkins, and Omplots. In the 1960s, the beginning of therapeutic catheterization was done by Charles Dotter, who developed an angioplasty of peripheral arteries, inserting coaxial, progressively larger and larger and larger catheters. Subsequently, this technique has been called dottering the vessel. And here, in fact, is a photo of the first case that Dotter ever did in an elderly woman. And this is her leg artery before, and a very nice result after using the dottering technique. In 1966, William Rashkind of the Children's Hospital of Philadelphia, known as CHOP, performed the first atrial septostomy with the balloon directed across the interatrial septum. Selective coronary angiography was an absolutely necessary diagnostic procedure that had to be developed before coronary artery bypass grafting, so-called CABG or CABG, could be done. Sones at the Cleveland Clinic made it possible by developing coronary angiography for Rene Favalero, also at the Cleveland Clinic at that time, to perform the first bypass surgery in 1967. In the first half of the decade of the 70s, techniques for improving the quality of angiographic studies were developed. Oblique axial views were added to the standard right and left views, as well as improvement in fluoroscopic equipment. This resolved the issue of false negative angiographic studies. You may wonder why I have a pillow in this corner of the slide. Well, before the days of being able to do axial studies, we had to prop the patient up to get cranial views, and really couldn't get good caudal views because you would have to have dropped them off the head end of the table, which frankly wasn't very practical. In 1970, William Gantz and Jeremy Swan introduced the pulmonary flow directed catheter. Of great interest, but we're not going to go there today, are the electrophysiologic techniques that would lead to the catheter-based diagnosis and treatment of arrhythmias. Anthony D'Amato in the mid to late 60s developed his bundle recordings, which led to arrhythmia induction and then catheter-based ablation of atrial foci and reentrant atrial circuits. Transcutaneous aortic valve replacement is a game changer for valve surgery, but this occurred in the 21st century and would require an entire lecture of its own. In the 1970s, we saw the birth of coronary angioplasty. An obscure Swiss physician started working on his concept of using catheter-based balloon technology to fix obstructed coronary arteries. Andreas Grunzig started constructing balloon catheters in his kitchen with his able assistant Maria Schlumpf. His activities soon caught the imagination of two American cardiologists, Simon Sturzer of New York and Richard Myler of San Francisco. Dr. Grunzig presented his first results in animals at a poster session at the American Heart Association meeting in 1976. And here he is discussing his results in animals to an enthused group of doctors. And here is his chart showing the results of his percutaneous coronary interventions on animals. In May of 1977, the first human coronary balloon angioplasty was performed intraoperatively in San Francisco with Grunzig, Myler in attendance, and the surgeon was Elias Hanna. The beginning of the coronary interventional era in 1977. Though Sturzer and Myler had hoped to perform with Grunzig in the United States the first catheter-based angioplasty in a human, because of less stringent governmental restrictions, Grunzig did the first coronary angioplasty in a man in Zurich, Switzerland, in the left anterior descending coronary artery of Adolf Bachmann on September 16, 1977. Here's a photo of the first coronary angioplasty. On the left is the pre-PTCA film showing the narrowing. In the upper left-hand corner, this is shown in the region where there is the dark circle. To the right is the 10-year post-PTCA result, showing the results still to be absolutely pristine. The first balloon catheter used clinically in September of 1977 is shown in this picture. Here are Grunzig, Sturzer, and Myler in a lighter moment on someone's Vespa. In November of 1977, Grunzig presented his first 4 cases of angioplasty at a packed standing room only conference at the American Heart Association meeting in Miami, Florida. Those who were close by, Nace and Sones, noted tears welling up in his eyes as he said, "This is a dream come true." This is the first publication of Grunzig's first 5 cases in The Lancet in February of 1978, and interestingly, it was published as a letter to the editor. It wasn't even a complete article. Some letter to the editor. Dick Myler and Cy Sturzer performed the first PTCA in the USA in May of 1978. Following his presentation at the American Heart Association meeting, Grunzig discovers there is such a great interest in his new procedure that he starts running courses in Zurich.
Yes.
So here's the question. What's the height?
What? Then what? Then he stops, yes.
And a lot of people have shown this now around us. You cited them as well in your paper. And now you come with your hypothesis that we make science. If it's really a large artery, then I would start with the G. Könnten Sie mit Ihnen Dr. Stenosis, Chief of Cardiology, so he is in the same.
So far, so good.
So far, so good.
That is not fair. Don't do that. I can't believe that. That is unfair. Wait till you come to the United States and then I will get you. You will be in big trouble.
So meet.
I did my first angioplasty in November of 1979 with Dr. Jerry Doris of then Milwaukee mentoring me. This patient had bypass surgery previously, and interestingly enough, he also had an anomalous left circumflex coming off the right coronary artery. Nonetheless, this was his lesion. Here's the balloon across, and here's the result afterwards. Acceptable by the criteria of those days. This is the guide catheter and balloon used in my first case. In 1979, in order to better track the results of the new procedure, the NHLBI formed a workshop in Bethesda and invited all those interested in the new technique to participate and share their experiences. All the pioneers were brought together in the same room, Judkins, Sones, Dodder, and Grunzig, and discussed the results in front of 150 enthusiastic participants. I was honored to be there and be a part of this very, very important meeting. In 1980, following one of his courses, Spencer King of Emory was riding a train with Grunzig when he offered that he would like to continue his activities in the United States. He felt constrained at his current hospital, and Dr. King asked if he'd like to move to Emory. He did so in September of 1980. Interestingly enough, Sones wanted him at the Cleveland Clinic, but apparently King was able to convince him to come to Emory, stating that the Cleveland Clinic was not a university and Emory was. In the autumn of 1980, Dr. Grunzig moved to Atlanta and held his first course in February of 1981. I was also honored to be present in this group of people at the first course held in the United States. Here's a picture I took of the Atlanta course in 1981 with Myler, King, and Grunzig discussing a case. And here's Dr. Myler and Dr. King watching the live video of Grunzig doing a case. Here's Grunzig, Dodder, and Myler and Sturzer at another presentation, and you can see the joy and the camaraderie that we felt in those early days of angioplasty. At the same time, the first studies were being done with the revolutionary family of drugs, the thrombolytics, streptokinase, urokinase, and the genetically engineered drug TPA. These agents were being studied in the setting of acute myocardial infarction. In the late 70s and early 80s, the thrombolytic drugs were being studied because of the evolutionary progression in our understanding of the pathophysiology of MI. The classic concept of an infarction occurring because of the progressive stenosis and then occlusion of the coronary artery was disproven by the discovery that 80% of the infarcts were caused by the formation of a clot in the region of a subtotally occluded plaque that in later years was proven to have ruptured. But more of this later. Over the next 5 years, the NHLBI registry was one of the most important sources in tracking the results of this brand new procedure. This was the first time a new procedure was tracked literally from its inception.
What would be an ideal catheter for coronary dilatation? Well, first of all, it should be as small as possible. Second, the balloon should be as big as possible, being as small as it is. Therefore, if I have a dilatation catheter which is as small as the guide wire, but has the capacity to inflate with a balloon up to normal size of 2 or 3 millimeter, that would be the ideal catheter.
Dr. Grunzig was the consummate teacher. I sent him a case for review, and he was nice enough to send me a letter back urging me on to pursue this case, which I might say did end successfully. On October 16, 1985, I co-chaired an angioplasty symposium at The Ohio State University and invited Dr. Grunzig. I had the honor of introducing him. He gave a superb update on the current status of PTCA to a standing room only audience. His talk was preceded by that of a cardiovascular surgeon who presented his experience with failed PTCA cases. Listen carefully to Dr. Grunzig's original remarks, because in retrospect, they have a very eerie feeling to them.
And in 1979, he became the physician-in-chief of the Department of Cardiology at the University of Hospital in Zurich. He left Switzerland to join Emory University in 1980 and we all know of his remarkable achievements through the years. We're very pleased to have him here and look forward to his presentation. Dr. Grunzig.
Thank you, Joe. Thank you all for the nice welcome and the opportunity to be here. I think we all look at our existence from birth to death as a short passage of time. But if you look that way to your appearance, your daily appearance, then you might become a little depressive.
Less than 2 weeks later, on October 27, 1985, Dr. Grunzig and his wife, Margaret Ann, were killed when the plane he was piloting crashed in an intense thunderstorm as they were returning to Atlanta from the Atlantic coast. His funeral was attended by hundreds of loyal disciples and friends. He was only 46 years old. Sones died the same year at age 66, as did Judkins, age 63, and Dodder, age 64. It was a tragic year for the pioneers of invasive cardiology. The original catheters, guiding catheters, and balloons as designed by Grunzig were manufactured by Schneider-Mentag in Europe, while the U.S. company USCI developed the first guide and balloon catheters here. The guiders were quite large, French number 9 French catheters, and were fashioned mostly after the Judkins coronary catheters. The balloon catheters were tipped with a several millimeter long wire, either straight DG2030 or angled DJ2030. The J hoping to be able to angle into side branches better than the straight wire catheter. And this is the first generation of catheters. Because of the rigidity and large size of these original balloon catheters and their very poor steerability, only lesions in the proximal straight portion of the arteries could be approached. Angioplasty would not have advanced much further had it not been for the development of the next important breakthrough in catheter technology, the guide wire. This was advanced by Drs. Martin Kaltenbach and especially Dr. John Simpson of California. Here you see the guide catheter, here you see the guide wire with the tip all the way out and the balloon fed over the guide wire into where the lesion is, and you can see as the balloon is expanded, you can see the dent where the obstruction is being expanded. Originally, it was thought that plaque was compressed by the balloon. Subsequent studies with the new imaging techniques, intravascular ultrasound and angioscopy, demonstrated that PTCA doesn't compress the plaque, but rather fractures it in multiple directions, thereby enlarging the luminal diameter and hopefully in the process not dissecting the vessel shut. And here you can see an intravascular ultrasound as the catheter is passed through the lesion, and you can see the obstruction, how it varies in its length and its degree of obstruction. Despite the high initial success rate of angioplasty, the recurrence rate of restenosis was quite high, 30 to 50% and even greater in long lesions. This led to the development of additional non-balloon techniques to try to reduce restenosis. There were three major ones: directional coronary atherectomy developed by Simpson, transluminal rotational atherectomy, or so-called rotablator or roto-rooter by Auth, and laser ablation with development by multiple developers. How good are they? Well, DCA used a shaving technique that was hypothesized to reduce plaque burden. A large number of comparative studies were done, and it was found out that it was no better than conventional balloon angioplasty, and certainly was more dangerous in terms of complications. Basically, this was a shaft with a cylinder with a shaver that would shave plaque into this cylinder, and then that would be removed. As I noted, this turned out to be no better than primary balloon angioplasty and was soon discarded. Percutaneous rotational atherectomy utilizes a diamond tip burr, the end of the catheter, which rotates up to 150,000 revolutions per minute. Because of the differential cutting effect, the burr only shaves, or I should say pulverizes, plaque. Normal soft tissue is deflected out of the way, undamaged. Think of the rotational saw used to remove a plaster cast that cuts through the cast but does not damage the skin. This is the rotoblator assembly, the control cables, the slider that advances the burr itself, which is here, and the pneumatic tubing that drives the slider. Here is the burr head magnified, and to the right you can see that the particles that the rotoblator system pulverizes in the upper left-hand corner are much smaller than red blood cells that are 9 microns in diameter and a 5 micron bead, so that these obliterated particles go through the vascular system and lodge in the reticuloendothelial system. Here you see how the differential cutting effect of the burr is used to go through and pulverize a plaque. Here you will see a rotoblator in action on an angiogram of the rotoblator being used in the left anterior descending coronary artery. You will note that instead of the rotoblator being advanced directly, a pecking motion is used as it goes through the obstruction, so as not to cause a complication such as dissection. PTRA was also subjected to numerous comparative studies, except for long calcified lesions, where the restenotic rate was still high. There was no significant difference. However, PTRA is still used to prepare a calcified lesion for stenting, but not as a standalone procedure. Lasers, basically they didn't work very well, and they have been used recently in some cases, especially in peripheral vascular disease, but the lasers never really came about to be a useful tool in the coronaries. With the introduction of so many new techniques in the field of angioplasty, it became more accurate to bundle all these procedures from PTCA to the acronym PCI, Percutaneous Coronary Intervention. Although the first transradial angiography was reported by Lucien Campeau in 1989, followed shortly thereafter by the first transradial coronary stenting by Ferdinand Jimenez in 1993, transradial coronary catheterization was relegated to backup access for patients without alternate arterial access. Although widely used in Europe, it didn't really catch on here in the States till around 2008. It's technically more difficult, but has a much lower bleeding rate and earlier embolization. Here's a picture of Campeau and of Jimenez, and here's a catheter being inserted via the right radial artery. I started doing these procedures in 1999, and at its peak, I was doing more than 50% of all my procedures, including angioplasty, via the radial artery, and this was in the early 21st century. This approach was used in morbidly obese patients where the femoral approach was virtually impossible. In the late 80s and early 90s, Rubin, Palmaz, Sigvart, and Schatz introduced the first stents into clinical practice. And they used the bare metal stents in the early days. The first generation were bulky and difficult to position. They showed great promise in reducing restenosis rates, which till now was the Achilles heel of angioplasty. Interesting story is that Schatz was to meet with Grunzig the Monday after the Sunday he was to return from his Carolina coast or Georgia coast. Unfortunately, that was the day after the tragedy occurred of Grunzig's plane crash. Although the 1990s great progress was obtained in proving trackability and deliverability of the stents, by the beginning of the 21st century, stents could be placed almost anywhere. But, and we see here some photos of what the current stents look like. And here's a stent on a deployment catheter, here's the balloon catheter, here's the stent, and here's the guide wire. And here's the assembly just before it's being inserted into the Tui-Bors connector and to be extended into the coronary artery. So is this the holy grail of angioplasty? Not quite, because there's still a 20% restenosis rate with these bare metal stents. So what do? In fact, the situation is even worse in vein grafts. Well, what occurs? Bare metal stents initiate a peculiar type of hyperplastic response to cause the restenosis. And this is totally different than atherosclerotic plaque formation. This causes smooth muscle hyperplasia and cannot be prevented by any of the prevailing mechanical or pharmacological techniques. A patient was either a responder or non-responder, and those that responded did not have this occur, but those that didn't respond would all have this smooth muscle hyperplasia, causing restenosis of up to 20% of patients who were stented. So what's the solution? Well, we tried various things. First was a cutting balloon with little coaxial blades to more evenly cut into the smooth muscle hyperplasia. This is the balloon. As you can see, when it's retracted, the blades go within the balloon, and when the balloon is inflated, the blades pop out, giving you a better differential cutting than the jagged cutting that you see with a standard balloon. Here's the results of a cutting balloon on a osteal lesion in a diagonal. Here's the cutting balloon inflated, and you will see that there's a wire down the LAD to protect the distal vessel, and of course here's the wire in the diagonal. Here's the balloon deflated, and here's a very nice final result using the cutting balloon in this LAD diagonal system. Brachytherapy, the use of either gamma or beta radiation was used, and this did provide a very nice response to the restenosis, with the restenosis being curtailed to less than 10%. It was, however, an involved procedure necessitating the use of radiology to be present as we inserted either beta particle radiation seeds or used gamma ray radiation. Beta particle radiation was the preferred method of using it because the radiation exposure is only up to 5 millimeters, whereas gamma rays extend hundreds of yards and is nowhere near as safe to use as beta seeds. And indeed, we got very good results with this somewhat involved procedure. And here you see the beads within a restenotic segment of a stent being applied through the catheter. In the late 1990s and first years of the 21st century, drug-eluting stents were developed that were coated with anti-proliferative agents that reduced the restenosis rates. These agents were rapamycin, paclitaxel, and sirolimus. Sousa, in Patrick Cerise's lab, inserted the first of these stents in the late 1990s, actually in 1999. Here you see the pre-lesion, here's the post-stented lesion, and here's the lesion 10 years later. Very superb results without any restenosis in this case. So our drug-eluting stents, the holy grail, we're getting much closer. Subsequent multiple studies have shown that the restenosis rate is under 10%. And it's been shown that sirolimus-eluting balloons may also be useful for in-stent restenosis of drug-eluting stents, so-called DES-ISR. I was the first one by serendipity to use a drug-eluting stent in the central Ohio region, and this was on April 25th, 2003, 2 days after they were released for use by the FDA. Adjunct devices that are used are the filter wire and thrombus removal system. Here's an animation of how the filter wire works. You'll notice the wires extended distally. The catheter enclosing the basket is extended and then withdrawn with the basket opening up. The balloon is extended, or the stent is extended, and the material goes downstream but is caught in the basket. The basket is then collapsed back into the catheter with the material in the basket, and the entire assembly is then removed without any material being embolized distally. Here's the filter wire being used in a patient. You will note that there's a high-grade obstruction at the origin of the saphenous vein graft. Next, you will see the filter wire distally, and you can see the basket as the loop distal to where the obstruction is. The balloon is then inflated and the stent inserted. And then the filter wire is removed back into the catheter with the basket being collapsed. Here the entire assembly is being removed. And here's the final result. Angiojet thrombus removal system was basically a suction device which would suck up clot material. And here, is, for example, is a right coronary artery where this is being done. And you can see that after the material is removed, the artery looks much better. Thrombolytics, there's been a marriage between technical and mechanical aspects of angioplasty and the pharmacology of the clotting mechanism, with acute myocardial infarction being the most obvious example. Myocardial infarction is a very serious clinical disorder. Understanding that thrombosis due to rupture of a vulnerable plaque and not progressive stenosis leading to occlusion was the cause of infarction was key to the developing groundbreaking appropriate treatments. Thrombolytics, rescue angioplasty, primary PCI for acute myocardial infarction. In 1980, Marcus DeWood reported thrombosis or clots as being the cause of an MI by doing angiography in the first 4 hours of an infarct. It was then shown that most infarcts were not caused by progressive narrowing to complete blockage, but rather by ruptured plaque and thrombus formation. In 1984, Peter Rentrup reported using a thrombolytic to produce clot dissolving in a patient with acute myocardial infarction. And in 1983, Jeff Hartzler of Kansas City reported PTCA for treating acute myocardial infarction. Here is a photo of the original article by DeWood in the prevalence of total coronary occlusion during the early hours of transmural infarction. Here's the paper by Rentrop showing the effects of intracoronary streptokinase and intracoronary nitroglycerin on improving the angiographic patterns and mortality in patients with acute myocardial infarction. And here's the paper written by Jeff Hartzler in his first case of percutaneous transluminal coronary angioplasty in acute MI. And here you can see that the LAD is totally occluded. The balloon is across the LAD lesion here. The balloon is inflated, and following that inflation, there's reopening of this total LAD. Angiography, being only an anatomic parameter, often under or overestimates the true significance of coronary stenosis. Additional parameters are necessary to delineate the true physiologic significance. These measurements have proven to be very important and indeed now guide how we proceed with angioplasty in any given case. In essence, it's a stress test, or at least a stand-in for a stress test of each individual artery. Fractional flow reserve, or FFR, is a measure of the pressure above the obstruction, usually in the aorta, and using a pressure wire, the pressure in the coronary artery involved beyond the obstruction in question. This value, if less than 0.75 to 0.8, is significant for ischemia, and the lesion should be treated if all clinical indicators otherwise indicate it. If, on the other hand, the value of that ratio is over 0.8, the obstruction is not critically significant in terms of reducing blood flow and thereby causing ischemia and need not be treated. The long-term prognosis is excellent with an FFR over 0.8. Here is a woman who had a left main artery stenosis of questionable significance in this particular view. Since we weren't sure whether or not this represented a critical left main obstruction, we went ahead and measured her FFR. It was found to be 0.89. We elected not to treat this lesion and follow her and treat her medically. Over the next year that we did follow her, she did very well and had no clinical events whatsoever. Those of you who are senior enough will recall that originally we all measured the distal pressure before and after PTCA and required a less than 20 millimeter gradient to be present to indicate a successful result. Brunswick initiated this practice and was measuring a PDPA, or a distal versus proximal pressure. He was way ahead of his time. Complex PCI is calcified lesions using rotoblator or orbital atherectomy and coronary lithotripsy. Unprotected left main lesions, chronic total occlusions are continuing to be a interesting problem which we are dealing with more and more successfully. Bifurcation lesions and in-stent restenosis. Techniques continue to be developed to improve the success and safety of these complex procedures. Here's an animation of orbital atherectomy, another method currently used to prep a calcified lesion. Here the guide wires advance through the calcified area. And then the orbital atherectomy device is used. Unlike the burr, which is a linear device, this is a rotational device that goes in orbit, and as it shaves off more and more plaque, the orbit increases so that one single device can be used rather than having to step up the linear atherectomy device, the rotational device. Both have been shown to be equally effective, and both are currently in use. And intravascular lithotripsy uses a shock wave within a balloon to fracture plaque, so it's more malleable and can be more easily stented rather than being like a rigid concrete tube.
So it's green, so it's ready to go.
In the lower right-hand corner, you will see a shockwave catheter used on ceramic plaques, and you can see how it fractures them. In the upper left-hand corner is an animation of the catheter in use. You will notice that as the balloon is placed there and the catheter activated and the shock waves started, the plaque starts to fracture. And you can see the fracture crevices occurring with each series of surges. This allows the plaque to become very malleable so that instead of it being a rigid concrete tube, a balloon and stent can then be placed without the resistance of a calcified plaque. Here we see 3 angiographic frames of coronary lithotripsy. On the left-hand frame, you see a calcified plaque. In the middle frame, you see the results after the lithotripsy has been done, and in fact, it looks like a good result of the old angioplasty balloon technique. This simply shows that the contrast is now within all the crevices of the fractured plaque. And in the right-hand panel, you can see the final result of the stented segment. Here we see optical coherence tomography of lithotripsy. We see pre-PCI in the upper panels and post-PCI in the lower panels. And you will note throughout all the plaque the difference between unfractured plaque in the upper panels and crevices throughout the plaque in the lower panels. Here's an example in the periphery of an Impella catheter used in a patient with cardiogenic shock where the catheter could not be advanced beyond this point in a highly obstructed common femoral artery. So the lithotripsy catheter was used, and here you see it being used. And of course, there's not much to see in a balloon being expanded, but here's the final result, allowing the Impella catheter to be passed all the way up past the point of what had previously been a high-grade obstruction, not allowing passage of the catheter. Numerous trials have shown that there appears to be a ceiling of 70–80% patency with the use of thrombolytics. Trials combining thrombolytics with platelet inhibitors have shown a modest improvement in patency rate. We now know that PCI is the alternative to the optimal treatment of acute myocardial infarction. Multiple studies have now demonstrated that morbidity and mortality, or so-called MACE, major adverse cardiac events, and improvement in LV function is not just a function of opening the artery, but rather returning blood flow to normal. Only angioplasty can consistently open the artery and produce normal blood flows. In those centers that have the ability to reduce the in-hospital arrival time to the cath lab to under 90 minutes, so-called door-to-balloon time, PCI is the preferred method of producing the best improvement in blood flow in the setting of acute myocardial infarction and also in mortality. It can also be used as a rescue procedure where the thrombolytic has failed to improve perfusion, or it can be used later in a case where a thrombolytic was used at a peripheral hospital and the patient then transferred for angioplasty to a tertiary care center. Acute myocardial infarction. 50-year-old man was brought to the emergency department with 3 hours of severe crushing precordial pain. His electrocardiogram, as noted in the lower left panel, showed changes in acute myocardial infarction of the inferior wall. Since he had no contraindication to thrombolytics, he was given TPA and transferred to a tertiary care hospital, where I met him in the cath lab. Upon arrival, he was taken to the cath lab, where his pain was still 4/10 and the ST segments were still elevated. The coronary angiogram showed the following. The right coronary angiogram shows that the thrombolytic has been partially successful with resumption of some flow, although flow distally is very poor. You can see the residual very tight stenosis in the mid-right coronary artery. The first stent is placed in the region of the very tight mid-right coronary artery stenosis. That stent is very nicely expanded, but one can see there is a residual, very tight stenosis in the distal right coronary artery. Here we see the stent placed in the distal stenosis before deployment. Here's the final result with both stents deployed, and an excellent result seen with a widely patent right coronary artery. In addition to powerful platelet inhibiting drugs, the 2B3A inhibitors and the thienopyridines have all been used to improve reduction in thrombotic and bleeding complications. Recently, it has been shown that the more important than the anticoagulant used is the skill of the operator and the growing use of transradial approach. In September of 2017, the 40th anniversary of coronary angioplasty, there was a reunion of some of the pioneers of coronary angioplasty in Zurich, Switzerland, where it all began. And here, in fact, is a picture of the index patient, Adolf Bachmann, hale and hearty 40 years later. Thank you to all those who helped to make it possible. Invasive interventional procedures are a team sport. These are not helpers, these are colleagues, and my hat is off to all of them, and my deepest thanks to the Mount Carmel lab crew in Columbus. There's the cath lab of Maitens and Sones in the 1950s, and here's our modern day cath lab. What a difference. And in these days of virtual reality, robotic remote control of PCI can now be done, where the operator can be miles and miles away while performing PCI in a remote hospital. What does the future hold? Mechanical equipment will continue to be refined, but the greatest advances will be made in the pharmacology of the treatment of restenosis using more conventional pharmacological approaches, drug-coated stents and balloons, but also, and probably more important, the introduction of newer therapies to retard plaque formation, specific anti-inflammatory therapy, and possibly even stem cells to regrow cardiac myocytes. But then, the true holy grail is the ability to prevent the development of occlusive plaque in the first place, so that none of this other stuff will ever be needed. That will be the challenge for the next generation.